It's my sincere pleasure today to be with a wonderful group of panelists regarding review of some GI cancer cases. My name is Dr. Kathy Ng from Vanderbilt Ingram Cancer Center, the David H. Johnson Endowed Chair in Surgical and Medical Oncology, and the co-director of the GI Research Program. Today we have some wonderful panelists, and we'll just go around and have them introduce themselves. So please introduce yourself, Carrie Siegel.
Hi, good afternoon. My name is Dr. Carrie Siegel. I'm an abdominal imaging radiologist at Washington University in St. Louis.
Hello, everyone. My name is Al Benson. I'm a GI medical oncologist at Northwestern University and the Robert H. Lurie Comprehensive Cancer Center, where I serve as one of the associate directors.
I am at Emory University and Winship Cancer Institute. My focus is primarily complex upper gastrointestinal and hepatobiliary surgery, and it's a pleasure to be here today.
I'm Preecish Patel. I'm an associate professor of radiation oncology at Emory University. I work closely with Dr. Kubi. Glad to be here today and to discuss some good cases.
51-year-old gentleman with a stage 2 T3N0 distal rectal carcinoma, no prior medical history, no known social contributory family history. MRI, which we'll review, shows a 3.8 centimeter mass, 3.5 centimeters from the anal verge, abutting the internal anal sphincter with 240-degree involvement. Colonoscopy identifies a 4 centimeter ulcerated mass just above the dentate line, and the pathology is MSI stable, consistent with adenocarcinoma. Dr. Siegel, can you please review these images?
Sure. On the left, we have a high-resolution sagittal T2 weighted view. And on the right, we have that, again, that sort of angled view. It's not quite axial, it's not quite coronal through the internal sphincter. And if you look at the image on the left, there's sort of a lobulated mass, more posterior than anterior, involving the distal rectum. When we look at the image on the right, it's circumferentially involving a large portion of the sphincter.
Thank you. Dr. Patel, can you comment on how you would want to approach this patient?
Yeah, I think this is a similar paradigm to a former case that we just discussed. So, sphincter involvement and the concern for permanent colostomy required with surgery. And so I think, again, starting with chemoradiation would typically be our preference. There's some controversy about when if there's involvement of the anal canal, and in this case, Dr. Siegel, do you think the anal canal itself is involved?
I do.
Okay, so when there's involvement of the anal canal, that for us raises the question as to whether the inguinal lymph nodes now become at risk, similar to anal cancer. And so that may also, again, change the radiation modality and the radiation targeting, where many would go and prophylactically target the inguinal lymph nodes in addition to the standard targets.
Thank you. Dr. Benson, do you have any comments about, would you approach this patient any differently?
No, this again is a total neoadjuvant approach with sequential therapy, including chemotherapy and chemoradiation.
Thank you. Dr. Kubi, what are your thoughts on this low-lying tumor?
Yeah, so this particular situation is more concerning for the need for an APR. So we, again, would hope that there'd be a tremendous response to the pre-op therapy so that this patient could be put in a watch and wait scenario. But if not, if you don't get that type of response, then this would almost certainly be an abdominal perineal resection.
Thank you so much.